Hello to all my dear students. Welcome to the recall session of the medicine questions asked in INICET November 2023. At the outset, let me tell you that it was a balanced paper of moderate difficulty level. If you scan through the questions, you will find that slightly more number of questions were asked from cardiology, endocrinology, hematology, and even infectious diseases. But yes, there were questions asked from other topics of medicine as well. So let's discuss the questions one by one. The first question is an ECG based question. Comment on the diagnosis from the ECG. An ECG strip was given and the options were first degree AV block, second degree AV block, third degree AV block, and none of the above. Okay. So most of the INICET exams will have one or two questions that are based on an ECG. Either they will be asking you regarding the diagnosis of an arrhythmia, or they may ask you regarding the management of a particular arrhythmia. Okay. So this time they have asked about diagnosing a particular arrhythmia. If you look at this ECG strip, you will find that initially you have got a PQRST, followed again by another PQRST, all looking good. But then you can see there is a P wave, following which there is no QRS complex. So you are having a non-conducted P wave. And after that, you can again see there is a PQRST. So since there is a non-conducted P wave, you are quite sure that you are dealing with an AV block here. Okay, you're dealing with an AV block. Okay, now the options are first degree AV block, second degree AV block, third degree AV block. How to differentiate between them? Now, if you remember in my lectures, I have discussed about the classification of bradyarrhythmias, which I have subdivided into two categories. One occurring due to a sinus node dysfunction and the second occurring due to AV conduction abnormalities. So AV conduction abnormalities may be first degree, second degree, and third degree. Okay. So as far as this question goes, I limit my discussion to the AV conduction abnormalities because that is what we are dealing here. Okay. Now, in case of a first degree AV block, okay, so the first degree AV block is what you are seeing in your screen right now, first degree AV block. So in a first degree AV block, okay, what are you going to see? You're going to see that there is a constant prolongation of the PR interval. Okay, so there is a constant prolongation of the PR interval more than 200 milliseconds. Okay, so the PR interval is prolonged. It is more than 200 milliseconds. More than 200 milliseconds is what you're going to see. But remember, it will be a constant prolongation and you will not be having any sort of a missed beat there. Okay, there is no non-conducted P waves here. Okay, now first degree AV block can happen because of drugs like beta blockers. Okay, and then if you look at second degree AV block, so second degree AV block, here you will have non-conducted P waves. But remember, second degree AV block, you can have second degree AV block. There is second degree AV block Mobitz type 1 as well as Mobitz type 2. First of all, let me tell you what is a Mobitz type 1. So in Mobitz type 1, what happens is there is a prolongation, gradual prolongation of the PR interval. So if you look here, you can see there is a gradual prolongation of the PR interval, following which there is a non-conducted P wave. And after that, again, you can see there is a gradual PR prolongation and again there is a non-conducted P wave. This phenomenon is what you refer to as a Wenckebach phenomenon. Okay, you call this a Wenckebach phenomenon. So Wenckebach phenomenon is associated with a second degree AV block Mobitz type 1. Whereas when you are dealing with Mobitz type 2, Let's have a look at this ECG. So here, if you look, you can see there is a non-conducted P wave. But if you look at the PR interval before that and also maybe after that, you can see all the PR interval is normal. Okay, all the PR interval is normal. Okay, normally you will have a PR interval of 120 to 200 milliseconds, and beyond 200 milliseconds is what you say as a prolonged PR interval. But you can see that in this particular ECG strip, the PR interval is normal. You can see that suddenly there is a missed beat. Suddenly there is a P wave which is not followed by a QRS. This is what you call second degree AV block. Second degree AV block, Mobitz type 2. Mobitz type 2. Okay, I hope that is clear. And then coming to the third degree AV block. So third degree AV block is what you are seeing on your screen right now. And if you look carefully, this is a P wave. And watch out, this is also a P wave, this is also a P wave, this is also a P, this is 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 P. Okay. And what I am marking in blue arrows, they are the QRS complexes. So if you look at a third degree AV block, what is happening is the PP interval is actually constant. Okay, the PP interval is constant. The RR interval is constant. The RR interval is constant. Whereas the PR interval is varying. PR interval is varying. Okay. So this is what you call an AV dissociation. Okay. So the atrial rate is constant, the ventricular rate is constant, but you can see there is a AV dissociation. Okay. So hallmark feature of a third degree AV block, which is also known as a complete heart block, okay, CHB or a complete heart block, is AV dissociation. Okay, so that is what you're going to see in a third degree AV block. So they asked about a bradyarrhythmia, and it is an AV block, and you can see that all the PR interval is actually normal except for one sudden missed beat. So you're talking of a second degree AV block, Mobitz type 2. But in the options, from what I understood from the student feedback, is that nothing was mentioned about Mobitz type 1 or Mobitz type 2. All that was mentioned was a second degree AV block. So your answer is going to be a second degree AV block. So the key to the diagnosis is you just have, once you find out there is a missed beat, you look at the PR interval before as well as after, and you look at the PR prolongations as well, okay, which will help you come to diagnosis quickly in the examination. So this is second degree AV block. Let's go to the next question. So another question, this is about, again, an arrhythmia scenario was given. A 16-year-old boy, okay, so we are talking about a 16-year-old boy admitted with complaints of sudden onset of palpitations. Okay, so the patient is having palpitations and he is around 16 years of age. It's a boy. An ECG was performed which showed a coved pattern of ST segment elevation. So this is probably the most important part of this question. A coved pattern of ST segment elevation seen in leads V2 and V3. So in the precordial leads V2 and V3, you had a coved pattern of ST segment elevation. And he is also having a history of unexplained syncope before. So maybe that again was an arrhythmia that led to a cerebral hypoperfusion. So there is a scenario of a patient who is around 16 years developing arrhythmias, okay, with a specific ECG change that is mentioned. What is the most likely diagnosis? Is it early repolarization variant? Is it Brugada syndrome? Is it hypertrophic cardiomyopathy? Or is it ST elevation myocardial infarction? So see, ST segment elevations are always a favorite area for the exams. And I've always in my lectures as well, in the ECG lecture, the particular portion where I've explained about the ST segment, I've had a detailed discussion, right, of the various conditions that can cause an ST segment elevation. And I've mentioned this specific terminology, that is a coved pattern of ST segment elevation. So we are talking about a syndrome that is a Brugada syndrome. Okay, Brugada syndrome. So what is this Brugada syndrome? See, Brugada syndrome is an autosomal dominant inherited condition which occurs due to a sodium channel defect. Okay, SCN5A, and males are more affected than females. In this question also, we are talking about a male. Now, what is the characteristic feature ECG finding in this condition? So, Brugada syndrome is characterized by more than 0.2 millivolt ST segment elevation with a characteristic coved ST segment elevation. So, there is a coved ST segment elevation, and there is a negative T wave in more than one of the anterior precordial leads, that is leads V1 to V3. Okay, so if you look at this, there are different types of Brugada, but the type 1 Brugada is characterized by this coved ST segment elevation, and also you can see that there is a T inversion, and the leads that you should be looking for these ECG changes in Brugada are V1 to V3. Okay, so V2 characteristically is showing the coved ST segment elevation here. Okay, right. So remember, in case of this Brugada syndrome, the ST segment elevation can wax and wane over time, and especially during illnesses like fever and a febrile illness, this ST segment elevation can be more pronounced. Okay, and when you administer sodium channel blocking drugs like flecainide or procainamide, this can augment or unmask the ST segment elevation in the affected individuals. Now, how do these patients present? Because Brugada, I'm sure that by now you know about the ECG changes in Brugada, but how do they present? So these patients present with syncope or maybe cardiac arrest, which can happen due to a polymorphic ventricular tachycardia. And many a times the cardiac arrest can occur during sleep and may be provoked by a febrile illness. So you can have patients with syncope, you can have palpitations, you can have patients landing up in cardiac arrest. So these are the points that you should be knowing. Okay. Now in this question, if you look back, you can see that the age of the patient is 16 years. So if you look at the options, you will find one of the options is an ST segment elevation MI. First of all, the clinical scenario is not giving you any sort of an ischemic chest pain, and also this is not the age where you would normally expect an ST segment elevation myocardial infarction. And moreover, this particular terminology, coved pattern of ST segment, that's not commonly associated with an ischemic ST segment elevation that can happen in a myocardial infarction. So this is a wrong option, ST segment elevation. Okay, and then regarding the other options, what about early repolarization variant? See, early repolarization variant, here again you will get an ST segment elevation, but again it's not a coved ST segment elevation. And as the term, this is a early repolarization variant, also known as a benign repolarization variant. So it's a benign condition. The patient is usually asymptomatic. You're not going to have a patient presenting with all these palpitations and a history of syncope. It's a benign condition, the early repolarization variant. So you're not going to have a symptomatic individual there, though you might get an ECG evidence of an ST segment elevation. Okay, right. Hypertrophic cardiomyopathy, again, you're not going to get the characteristic coved ST segment elevation. Yes, you can have a 16-year-old boy with palpitations or dyspnea on exertion. You can have those features, but again, ECG finding is not suggestive of any sort of a hypertrophic cardiomyopathy. Okay, and mostly they ask in exams a clinical scenario of a football player with a sudden death. So, and they might give you a gross image as well of a patient with hypertrophic cardiomyopathy. So what is the characteristic gross findings of a patient with hypertrophic cardiomyopathy? You might see that there is asymmetrical septal hypertrophy, correct? So there will be disproportionate ventricular hypertrophy, which is more involving the interventricular septal region compared to the left ventricular free wall. So that is what you have got to remember about hypertrophic cardiomyopathy, which is not going to be the answer here. And can you tell me, in this particular patient, next time if they slightly twist the question and ask you how to manage this patient, what is the treatment of choice? The treatment of choice is going to be an ICD. Okay, so the treatment of choice is going to be an ICD in this case. Okay, in case of Brugada syndrome. Okay, right. So that's what I've mentioned here. An ICD is indicated for individuals who have unexplained syncope or has been resuscitated from cardiac arrest in case of a Brugada syndrome. So as I told you, Brugada syndrome is an inherited arrhythmia syndrome. What are the other inherited arrhythmia syndromes? You have got the long QT syndrome, Brugada I've just mentioned, and ARVC, which is arrhythmogenic right ventricular cardiomyopathy. You can even expect questions based on long QT as well for your INI-CT exams. Okay, but this time they have asked about Brugada syndrome. Okay, and another potential question area is on the differential diagnosis of an ST segment elevation. So ST segment elevation, myocardial infarction, LV aneurysm, acute pericarditis. So acute pericarditis, you can have a concave type of ST segment elevation, a benign early repolarization variant, left ventricular hypertrophy and LBBB may also be associated with an ST segment elevation, Brugada syndrome, and electrolyte abnormalities like hypercalcemia, hyperkalemia, and hypothermia can also present with ST segment elevation. And remember, another potential MCQ, a previous question, is on the Osborn wave, which is the J wave that is seen associated with hypothermia. So hypothermia can have a J wave or an Osborn wave, just like a camel hump. Okay, you can see that a camel hump sort of projection you can see as the Osborn wave seen in hypothermia. So, basically coming back to the question, the answer here is Brugada syndrome. Okay, answer here is Brugada syndrome. Coming to the next question, which of the following will be the ideal method of collecting blood cultures for the diagnosis of infective endocarditis? So you know that in the diagnosis of infective endocarditis, you have got the modified Duke's criteria. Okay, modified Duke's criteria. And one of the major criteria depends on the establishing the organism through the blood cultures. So blood cultures are very important in the diagnosis of infective endocarditis. And when you send samples for blood culture in the diagnosis of infective endocarditis, there are a few points that you have got to be careful about, which I've explained in my lectures as well. So you will collect 3 blood culture sets, okay, over a period of 24 hours. So over a period of 24 hours, you will collect 3 blood culture set. Each set will consist of 2 bottles. Okay, why 2 bottles in each set? One is for aerobic and other for anaerobic culture. So each will have 10 ml per bottle. So each set will have 10 ml of aerobic and 10 ml anaerobic as well. And as I said, over a period of 24 hours, but there should be a minimum gap of 1 to 2 hours between the collection of each individual set of blood cultures. Okay, so minimum gap of 1 to 2 hours. Okay, so you're collecting 3 sets of blood cultures from separate venipuncture sites 1 hour apart. So this is the ideal way to collect the blood cultures in case of infective endocarditis. Next question, a 75-year-old woman with type 2 diabetes mellitus and hypertension developed features of heart failure and expired. Post-mortem cardiac biopsy slide is given, and what is the diagnosis? So the autopsy specimen, the stained slide was actually given. See, the first point you have got to look is the age of the patient. So he's a 75-year-old woman with comorbidities like diabetes and hypertension, and the patient expired due to heart failure. Okay. If you look at the slide, what is striking here is that you can see this, there is a pink material that is getting deposited. Yes. So what do you think at this particular age, this pink material that gets deposited in the heart, what could it likely be? It is likely to be amyloid. Okay, it is likely to be amyloid. Okay, it is likely to be amyloid. And amyloid deposition can very well cause what? Restrictive cardiomyopathy. So here the likely diagnosis is restrictive cardiomyopathy. Whereas in case of the other options, you might ask me, sir, why not dilated cardiomyopathy? So dilated cardiomyopathy, see, number one, it is unlikely to present at this age for the first time, unless it is some sort of an ischemic dilated cardiomyopathy. But then again, you will have this typical ninja star appearance. Okay, what you're seeing, the nucleus, you can see the other arrows also pointing towards it. You will have a ninja star appearance of the nucleus. So that has to be there, and it was not given in the slide. Okay, all that was given was the pink amyloid material. And what about hypertrophic cardiomyopathy? So hypertrophic cardiomyopathy, what is going to happen is you will have cardiac myofiber disarray. So that is a characteristic histopathological finding, is a myofiber disarray, very haphazardly arranged fibers, the normal parallel arrangement all getting distorted, and there is a total disarray in case of a hypertrophic cardiomyopathy. Okay, Takotsubo, it's basically a condition where you can have some sort of an apical ballooning, but none of the the amyloid deposition is not going to be associated with a Takotsubo cardiomyopathy. So the answer here is going to be a restrictive cardiomyopathy. A restrictive cardiomyopathy. So restrictive cardiomyopathy is a condition that is characterized by a prominent diastolic dysfunction with stiff and non-compliant. So why is it stiff and non-compliant? Is because of the deposition of amyloid, which would actually make it more stiff. So whenever there is a small increase in the ventricular volume, this causes the ventricular pressure to rise so much. Okay, and gross finding wise as well, suppose next time they slightly twist the question and give a gross finding. So gross finding as well, the characteristic finding in case of a restrictive cardiomyopathy is that the atria, both the atria will be pretty much enlarged. You will see that the ventricular size dimensions will more or less be normal, but the atrial cavity will be very much enlarged because the ventricle is stiff. So the atria has to pump against stiff ventricles. So the atria will be compensatorily enlarging. So there will be dilated atria. Whereas in case of dilated cardiomyopathy, you will be having flabby dilated ventricles which are having thin walls. Whereas in hypertrophic cardiomyopathy, I've already told you about the asymmetrical septal hypertrophy that can occur. Okay, so what are the causes of the restrictive cardiomyopathy? It can be idiopathic. Amyloidosis is an important cause. Endomyocardial fibrosis, hemochromatosis, these are the common causes of restrictive cardiomyopathy. Okay, so diagnosis is going to be restrictive cardiomyopathy. Next question. Question is about a 50-year-old diabetic male presenting with a central chest pain, shortness of breath and palpitations. You had an ECG suggestive of non-ST segment elevation myocardial infarction. Which is the best combination for initial management was asked. Is it aspirin plus statin? Is it aspirin plus clopidogrel? Is it aspirin plus clopidogrel plus low molecular weight heparin, or is it aspirin plus low molecular weight heparin? So here they have asked about an ischemic heart disease, that is a non-ST segment elevation myocardial infarction. Okay, so they've given a clinical scenario of a myocardial infarction. Now, what is the best combination? See, if you look at the options, you can see that aspirin was there in all the options. Okay, aspirin is an antiplatelet drug, and the last two options had an anticoagulant as well. So it is very clear that in the management of non-ST elevation myocardial infarction, you will have a role for the antithrombotic therapy, which includes anticoagulation as well as antiplatelet. Okay, you're not going to thrombolyze this patient, but you have to have an antiplatelet as well as anticoagulation. Now, if you go back to the non-ST segment elevation myocardial infarction management that I've taught you, I've told you that antithrombotic therapy will consist of antiplatelet therapy as well as anticoagulation. Antiplatelet therapy will consist of a loading dose of dual antiplatelets, that is aspirin plus P2Y12 blockers. So aspirin 300 milligram plus either clopidogrel 300 to 600 milligram. Okay, you go for 600 milligram, especially if you are planning for an early invasive PCI. And ticagrelor 180 milligram, prasugrel 60 milligram. These are all the loading doses. Okay, so we're talking about the loading dose of an antiplatelet, and you will give loading dose of statin as well. Okay, loading dose of statin is also given, and then you may consider a GP2B3A inhibitor like apixaban or eptifibatide, tirofiban, but that is again only in patients in whom you are going for an early invasive strategy like a PCI. Anticoagulation with either unfractionated heparin or a LMWH or a fondaparinux or bivalirudin. So the point here is this. If you look at the options here, now aspirin is there in all options. What about option 1? Is it not right? You are giving a loading dose of statin as well. It is correct only. But if you want to pick the best option here, you will have to go for a combination of the antiplatelet plus anticoagulation, which is most crucial. Okay, so you'll go for dual antiplatelet, aspirin plus clopidogrel, and then you will have the anticoagulation as well. So option C will be the best combination here. Okay, so I hope that is clear. It's not that statin is not given, it is given, but the best option here will be option C. Now coming to the next question. Which of the following drugs has the best mortality benefit in chronic heart failure? Now, if you look at the options, all these agents can be used in the management of chronic heart failure. But it's a usual repeat question on what are the drugs that are having mortality benefit. See, furosemide and digoxin, though they can be used in case of heart failure management, they are not having mortality benefit. That is, they are not going to prolong life. You will have symptomatic relief, but mortality benefit is not there. Okay, they will not increase that longevity. So longevity is increased by certain drugs, especially one is ARNI, that is the angiotensin receptor blocker with neprilysin inhibitor, that is the sacubitril valsartan combination. Then you will have AC inhibitors and ARBs, AC inhibitors and ARBs. Okay, then you can have beta blockers, even spironolactone is there. Okay, spironolactone is there, and also even the SGLT2 inhibitors. Okay, and also even your hydrazine plus nitrate combination as well can have some mortality benefit. So overall, the best is ARNI, but the ARNI is not in the options. Now, what is there in the option is you have got AC inhibitors and also you have got carvedilol, which is a beta blocker. So both of them are having mortality benefit, but again, I would suggest that you pick up AC inhibitors as the best choice here, because after ARNI, the best evidence for mortality benefit is for the AC inhibitors and ARBs. So if you have got that as an option, you can pick it above the beta blocker. So my best answer will be AC inhibitors. Okay, right. So 26-year-old female presents with menorrhagia. There is a history of bleeding disorder in father and sister. So we are talking about a bleeding disorder here. Okay, so currently it is a menorrhagia presentation. There is a family history. Okay, there is a family history, and the family history is there in father and sister. More importantly, one is a male, one is a female. They've already given the pattern of inheritance as autosomal dominant. Okay, so I think that made the question, even more easier. What is the likely diagnosis? See, when you get a bleeding disorder, I've always told you that you can have a bleeding disorder because of a problem with primary hemostasis or secondary hemostasis, right? Remember primary and secondary hemostasis, and all the platelet abnormalities or platelet-like disorders they would present with primary hemostatic abnormalities. Even your vascular endothelial abnormalities will cause problems with primary hemostasis, whereas clotting factor defects will cause problems with secondary hemostasis. Okay, so here you've got menorrhagia, and there is a autosomal dominant pattern of inheritance. Now, if you look at hemophilias, okay, hemophilia, you know, it is an inherited bleeding disorder due to deficiency of clotting factor 8, which is hemophilia A, clotting factor 9, which is hemophilia B or the Christmas disease, and then clotting factor 11, that is hemophilia C. Now, the first one definitely can be ruled out. The second one can also be ruled out. Why? Both of them are X-linked recessive. Okay, X-linked recessive. And hemophilia C, the pattern of inheritance is autosomal recessive. Okay. And then, you know, you've got the acquired hemophilia where you can have antibodies against clotting factors, commonly clotting factor 8. So coming back to the options, you can see hemophilia A is out, hemophilia B is out, hemophilia C is out. Von Willebrand disease is predominantly autosomal dominant, can be autosomal recessive, certain subtypes. So basically, von Willebrand disease is a disease that is characterized by a quantitative or qualitative defect in the von Willebrand factor. And where do you get this von Willebrand factor? It is present in the plasma as well as the subendothelial extracellular matrix. That is where you get the von Willebrand factor. And a von Willebrand disease is the most common inherited bleeding disorder. This is very, very important. So in my lecture in the app on the approach to bleeding disorders, I have explained to you how important the role of the subendothelial von Willebrand factor is in establishing the connect between the platelet as well as the subendothelial collagen whenever there is an endothelial injury. Initially by causing a platelet adhesion by help of the 1B9 receptor, and subsequently after that platelet aggregation with the help of glycoprotein 2B3A receptor. So this particular image I have explained already in my lectures. Okay. So family history is always very important in a bleeding disorder. X-linked inheritance with hemophilia A and B. But if you see the question, even if they are not mentioned about autosomal dominant inheritance, so since the disease is there in both the father and sister, this is unlikely to be any sort of an X-linked recessive condition. Okay, right. So autosomal dominant von Willebrand disease type 1, 2A, B, 2B and 2M. Autosomal recessive von Willebrand disease type 2N, 3, Glanzmann's thrombasthenia, Bernard-Solier syndrome, and hemophilia C. These are autosomal recessive conditions. Okay. So in this question, I think the likely answer is von Willebrand disease. Now suppose, you know, they had not mentioned this line as pattern of inheritance is autosomal dominant. How would you come to the answer? So it is there in father and sister for sure. Then, you know, you can rule out the X-linked disorder, that is hemophilia A and B is out. Why not this is autosomal recessive? See, when there is a strong penetrance like this, when multiple members of a single family are affected, then that is more likely to be autosomal dominant. Okay, so I would pick von Willebrand disease even if that particular line of inheritance was not there. Okay. In sickle cell anemia, which of the following drugs can reduce the vaso-occlusive crisis? Is it methotrexate, azathioprine, hydroxyurea, or L-Trombopag? So there are various treatment options available for sickle cell disease. The most important one being hydroxyurea. Then you have got drugs like voxelotor, crizanlizumab, glutamine, transfusion, and then you have got stem cell transplantation. Out of the drugs, the most important one is hydroxyurea, which acts by inducing more formation of the fetal hemoglobin, that is HbF. But it's usually when, you know, it is not responding to hydroxyurea, you will try other drugs like crizanlizumab and glutamine. But here they have asked about hydroxyurea, which is very useful in preventing the vaso-occlusive crisis here. Okay, hydroxyurea. You're not going to use methotrexate, azathioprine or L-Trombopag in this condition. 30-year-old female who is a strict vegetarian. Okay, I'm sure that this would give you a hint about the answer. Presenting with pallor, there is anemia and MCV is increased. It is 110 femtoliter. So it is increased MCV. You are talking about a megaloblastic anemia, most likely due to a vitamin B12 deficiency because vitamin B12 deficiency is likely to happen in strict vegetarians. Okay, so this is a megaloblastic anemia due to a vitamin B12 deficiency. Okay, right. So megaloblastic anemia is the answer. A female patient with bleeding and isolated thrombocytopenia, which of the following tyrosine kinase inhibitor can be used? So bleeding and isolated thrombocytopenia. Okay, bleeding and isolated thrombocytopenia. So you're probably thinking about, since it is a female patient, you're talking about an immune thrombocytopenia, that is ITP. Okay, so they're asking which tyrosine kinase inhibitor can be used. So bosutinib and fostamatinib, both of them are tyrosine kinase inhibitor. So you know that the tyrosine kinase inhibitors will end with this nib. So it is very obvious from the question itself, it's either option A or option B. But bosutinib is actually used in chronic myeloid leukemia, CML. Okay, whereas this one is the one that is used in ITP, and that is going to be the answer here. Okay, so when it comes to the management of immune thrombocytopenia, which was previously known as idiopathic thrombocytopenic purpura. So immune thrombocytopenia will have first line therapy, which can be either steroids, intravenous immunoglobulins, anti-D immunoglobulins supported by platelet transfusion as and when needed. And second line therapy, you can have splenectomy, rituximab, thrombopoietin receptor agonist, and a spleen tyrosine kinase inhibitor. So the spleen tyrosine kinase inhibitor is this drug fostamatinib. And what is the importance of this splenic tyrosine kinase inhibitor? This will reduce the phagocytosis of the antibody-coated platelet. So if you recollect the pathogenesis of ITP that I have taught you in my lectures, I told you there is a destruction of the antibody-coated platelets by the spleen. So that phagocytosis is reduced by this drug fostamatinib. You can also use thrombopoietin receptor agonist, which are romiplastim, L-Trombopac, and Avatrombopag. So this is important. I think previously there has been a question on these drugs. Okay, like they have asked about mechanism of action of romiplastim sometime back in INICT as well. So they can be used in ITP by causing megakaryocyte maturation, proliferation, and differentiation, and they cause increase in the platelet production. Okay, so the answer is fostamatinib. Okay, right. So that is clear. And romiplastim, I have already explained. Oprelvecin can be used to increase platelet counts, but that is in a different scenario in patients who are, having malignancies and all. And there is a thrombocytopenia. You can use this drug oprelvecin, and this is acting by targeting the interleukin, that is interleukin 11. Okay, right. So this is not a tyrosine kinase inhibitor, oprelvecin. Okay, right. Next question is about transferrin saturation. So transferrin saturation decreases it. They've asked about transferrin saturation decreases it. Is it pernicious anemia, iron deficiency anemia, hemosiderosis, or hemochromatosis? So let's try to find out what is this TSAT or percentage transferrin saturation. So percentage transferrin saturation, the formula is serum iron divided by TIBC into 100. So that is how the formula is. So if you look here, the serum iron TIBC. Okay, so they have asked about decrease in transferrin saturation. Now what happens in iron deficiency anemia is that the serum iron can be low. Okay, and the TIBC can increase. So because of that, this ratio transferrin saturation will decrease in case of iron deficiency and will increase in case of iron overload state. So here in iron deficiency anemia, there is a decrease, whereas hemosiderosis and hemochromatosis, which are iron overload state, the transferrin saturation actually increases. Okay, whereas transferrin saturation has nothing to do with pernicious anemia at all. Okay, right. Next question, which of the following anti-diabetic drugs is approved for use in patients with heart failure with reduced ejection fraction and also having renal impairment with reduced urine output? So the scenario is that of a patient with a heart failure with reduced ejection fraction, and he's also having a renal impairment with reduced urine output. So they're asking which anti-diabetic agent is approved. Okay, now The options are linagliptin, empagliflozin, insulin diglodec, and rosiglitazone. See, most of the INI-CT questions, there is a trend towards asking questions either based on the incretin-based therapy or maybe regarding SGLT2 inhibitors. So if you look at the option empagliflozin is an SGLT2 inhibitor. Okay, whereas linagliptin is a DPP4 inhibitor. Okay. Now let me just quickly take you through this, DPP4 inhibitors and SGLT2 inhibitors. See, when you talk about the incretin-based therapy, that is, that the incretin hormones are GLP-1 and the GIP. These are gut hormones that can potentiate the postprandial insulin secretion. And these are broken down by an enzyme. And what is that enzyme? Dipeptidyl peptidase 4, DPP4. Okay. So the incretin-based therapy, you have got the GLP-1 receptor agonist, which are peptide hormones which will mimic the action of GLP-1. And most of the GLP-1 receptor agonists are given by subcutaneous injection, potential MCQ, which is the orally administered GLP-1 receptor agonist. It is semaglutide. Okay. So this is actually having a structural homology to the native GLP-1, which is an incretin, but they are actually modified slightly so that they are not easily broken down by the DPP4. Okay, so you can see that the GLP-1 agonists are having lots of actions. Okay, so not just reducing the blood sugar levels, but they are having important actions on the myocardium, the vascular endothelium, gastric emptying. They can cause sodium excretion. They can decrease the liver fat, decrease the insulin resistance, increase insulin, decrease glucagon, decrease appetite, decrease satiety. So a lot of actions are there. So remember, the GLP-1 receptor agonists, they are actually having, cardioprotective actions as well. Okay, but when it comes to DPP4 inhibitors, which is linagliptin that is given in the question, so they are actually preventing the breakdown of the endogenous GLP-1 and GIP. The examples are sitagliptin, linagliptin, alogliptin, vildagliptin, and saxagliptin. And remember, the only DPP4 inhibitor that does not require dose reduction in renal impairment is linagliptin. So linagliptin is the DPP4 inhibitor that does not require dose reduction in renal impairment. Now, if you look at the question, I am sure that at least some students would have had a doubt. So they're asking about heart failure with reduced ejection fraction, and there is a renal impairment. Okay. Now, there is a previous question on which of the following DPP4 inhibitor can be used in patients having renal impairment, and the answer is linagliptin. So many students actually marked linagliptin for this question as well. But if you read the question carefully, it's not just asking about any anti-diabetic agent which can be used in renal impairment. The agent should primarily help in patients having heart failure with reduced ejection fraction as well. Now, if you look at DPP4 inhibitors, in my lectures also I've told you that it is less potent. DPP4 inhibitors are less potent than the GLP-1 receptor agonist. There is only moderate glucose lowering activity, but importantly, they do not improve cardiovascular outcomes. So unlike the GLP-1 agonist, the DPP4 inhibitors, they are not improving any sort of a cardiovascular outcome. So that cannot be the answer to this question here. Okay, that cannot be the answer to the question here. So once again, if you look at this slide again, which I have taught you in my lecture on the treatment of diabetes, when you pick up agents for the treatment of diabetes, always the first choice agent is going to be metformin, no doubt about it. The second agent is opted when the HbA1c is still above 7.5 despite treatment with first line OHA. Now, when you want to choose a second line OHA or a second OHA in addition to metformin, remember in my lectures I have told you, in case the patient is having atherosclerotic cardiovascular disease or heart failure or a chronic kidney disease or a combination, you will either go for SGLT2 inhibitors or GLP-1 agonist. Okay, now this is a scenario which we are having in this particular question. Okay, remember there is no DPP4 inhibitor here. If the patient is overweight or obese, you can either go for SGLT2, GLP, and here comes DPP4 inhibitors. They are useful. Okay, but when there is a cardiovascular issue as well, you cannot be thinking of DPP4 inhibitors. You have got to either pick SGLT2 inhibitors or GLP-1 agonist. Okay, and just to complete the remaining part of that discussion, if there are cost issues, that is when as a second line you will go for either sulfonylureas or thiazolidinediones. Okay, so this particular slide which I am talking to you is about the choice of agents used in the treatment of diabetes. What is the second agent? So here the answer is going to be empagliflozin. Okay, the answer is going to be empagliflozin. So next question is about a 20-year-old male with the type 1 diabetes mellitus presented with a diabetic ketoacidosis. So pH is 7.2, RBS is 450, and I think the question was how should insulin be administered? So when it comes to complications of diabetes, there are acute complications as well as chronic complications. In the acute complications, you can have diabetic ketoacidosis as well as hyperglycemic hyperosmolar state, and many a times they do ask you questions based on the diabetic emergencies. Mostly diabetic ketoacidosis, they ask you either they give you a clinical scenario and they ask you something about the management part, or maybe they might bring in some ABG report as well and then ask you a question here. So here though they have given a pH and the RBS, but I think what they asked is only how the insulin is administered. Is it IM, subcutaneous, or bolus followed by continuous insulin infusion? So route of insulin administration in diabetes, remember the preferred agent is regular insulin, which is initially given as a bolus dose of 0.1 units per kg, followed by an infusion of 0.1 units per kg per hour. And the expected fall of the blood sugar in the first hour is 50 to 70 milligram percentage. You will not target more than that, because if you suddenly bring down the blood sugar, this can also produce some sort of an osmotic shift. So you're not interested in that. And only if the fall is not as expected, you will think of doubling the initial bolus dose. Okay. And then once the RBS reaches 200 milligram percentage, you will reduce the rate of infusion. And while you administer the insulin infusion, it is very important to closely monitor the serum potassium, which might actually go down, because insulin can cause some sort of a potassium redistribution, shifting the potassium from the extracellular compartment. So from the ECF, the potassium can come inside, which may lead on to hypokalemia. And closely monitor the ABG as well. A transition to subcutaneous insulin is done only if the patient is taking food orally and you're sure that there is less chance of the patient going for a hypoglycemia. But even then, remember, even when you start the subcutaneous insulin, you will have to overlap with 1 hour of infusion. Otherwise, if you suddenly stop the infusion and then start subcutaneous, the subcutaneous will take some time to act. Okay, say 30 minutes to act. So during that particular time, again, there is a chance that the blood sugar levels can again go up. So for this particular question, the answer is going to be option C, an IV bolus followed by a continuous infusion. Okay. The next question, what is the most common cause of hypercalcemia in hospitalized patients? Okay. So calcium abnormalities, again, hot favorite. Usually they ask more about hypocalcemia. This time they have asked about hypercalcemia. And they've asked a simple question on the etiologies of hypercalcemia. So in my lectures, I've taught you about the various causes of hypercalcemia, which can be due to excess PTH production, which may be a primary hyperparathyroidism, tertiary hyperparathyroidism. And a primary hyperparathyroidism can occur due to an adenoma, hyperplasia, and rarely a carcinoma. Then you can have the hypercalcemia associated with various malignancies. Hypercalcemia is associated with excess vitamin D, which can either be iatrogenic, you are taking too much of vitamin D, or maybe in granulomatous diseases like sarcoidosis, wherein the granulomas can promote active vitamin D formation, in that case also the calcium levels can go up. But since they have mentioned that it's a hospitalized patient, okay, so it's a severe symptomatic hypercalcemia that you're talking about, okay, you're talking about a severe symptomatic hypercalcemia, okay. So what is the most common cause of a severe symptomatic hypercalcemia? That is mostly due to malignancy, okay. Patients who are having malignancies can have severe symptomatic hypercalcemia, okay, right. So that is the answer here. Malignancies is the answer, okay. So parathyroid adenoma, parathyroid carcinoma, adenoma, hyperplasia, they can all cause hypercalcemia. Even vitamin D intoxication can cause, but a severe symptomatic hypercalcemia is usually due to a malignancy, okay. Next, identify the disorder based on the physical features. From what I understand from the students, I think, they had given a scenario of a patient who had, a protruded jaws. So typical facial features with frontal bossing. So suggestive of acromegaly. Okay. So simple question. And just to recap the important facial features of acromegaly: coarse facies, frontal bossing, prominent supraorbital ridge, prognathism, macroglossia, there is a gap between the incisors, jaw malocclusion, large fleshy nose and thick lips. All the features may not be present in the single individual, but again, I think in this particular question, frontal bossing was there, prognathism was there, and the general gigantic figure was there, all suggestive of acromegaly. But remember, in addition to these facial features, you can have other features as well, like cardiomegaly can be there, you can have colonic polyps can be there, cardiomegaly can be there. So all those other features can also be there in case of acromegaly. So the answer here is acromegaly. Okay. Cushing syndrome can have all the typical Cushingoid features, including the striae and the moon facies, but that was not described. And it's anyway not going to be Addison's disease and diabetes because they do not have any obvious physical features that are going to tell you the diagnosis, except for maybe, the pigmentation in case of Addison's disease. Patient on rheumatoid arthritis who was on long-term treatment suddenly stopped his medications. So the patient was on medication. They have not told which medication, but anyway, he has suddenly stopped the medication. Following which he is developing certain unique features, one of which is hypotension, hyponatremia, and hyperkalemia. Now, if you remember, I've taught you about the management of rheumatoid arthritis. So rheumatoid arthritis, for acute pain relief, you can go for NSAIDs as well as steroids. Whereas for chronic management, you have got the disease-modifying anti-rheumatoid drugs, which include drugs like methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, as well as the various biological drugs like infliximab. A lot of biologicals I've already told you. But here, they've not mentioned which drug, but suddenly stopping the medication, hypotension, hyponatremia, hyperkalemia. See, these are features of a sudden steroid withdrawal, which can lead on to an Addisonian crisis. Okay, remember, patients who are taking steroids for long, when they suddenly stop steroids, even rheumatoid arthritis also, maybe the patient is having severe pain. So because the patient is having severe pain, the patient is continuously taking steroids as well. Okay, some patients with rheumatoid arthritis, with severe painful rheumatoid arthritis, might even require longer term steroids. Okay, because whenever they are stopping the steroids, the pain might reappear and they may not be affording for any biological treatment. So they might, continue with steroids. Now, when you suddenly stop steroids, what happens is that because you were taking steroids, your pituitary was not producing ACTH. Because of the feedback loop, there was a decreased production of ACTH. So when there is sudden stoppage of the exogenous steroids, the ACTH production from the pituitary is not enough or not adequate to maintain the adrenal production of the various cortisol and all. Okay, so because of which you can have an Addisonian crisis. And in the management of the Addisonian crisis, the patient is in hypotension. Fluids, everything is important, no doubt, but the most important part is intravenous hydrocortisone that has to be given very urgently. Along with that, fluid replacement is also important. So hydrocortisone is the drug that should be given urgently. Okay. Then post bilateral adrenalectomy, a patient developed hyperpigmentation of the fingers. What is the likely cause? So when you have got a bilateral adrenalectomy, following which there is an ACTH overproduction, you can have the formation of a tumor in the pituitary because of the ACTH production. And this is what you call as what? Nelson's syndrome. Okay. So Nelson's syndrome, what's the answer that is given? So it is not Conn syndrome, which is a primary hyperaldosteronism due to an adrenal adenoma, not Cushing syndrome. Okay. And students told me it was not Addison's disease. They told me that it was Addison's disease that is given in the option, but that is also wrong. So Nelson syndrome is the answer here. Okay. So Nelson syndrome is a term that is used to describe the enlargement of an ACTH producing tumor in the pituitary gland following a surgical removal of the bilateral adrenal glands, especially in case of a Cushing's disease. Okay. And another scenario of an obese female with similar lesions over the neck region. I think a simple Dolly question on acanthosis nigricans. Okay, so especially who are having metabolic syndrome profile, they can have such sort of dark velvety lesions, and that is acanthosis nigricans. Okay, 26-year-old female presented with tremors, sweating, palpitations, and diarrhea. Which of the following is the initial best test? So from what I got from the students, there was no option of free T4 in the options. They are given free T3, USG thyroid, TSH, and anti-TPO. Now, whenever you are trying to establish the diagnosis of the thyrotoxicosis, initially, if you look at the algorithm from Harrison, you will have to measure the TSH as well as the T4. Okay, you will have to measure the TSH as well as the T4. And based on that only, you will come to a diagnosis. I agree that the follow-up of patients with thyrotoxicosis is with the T4 levels, but for establish the diagnosis, you will measure the TSH and unbound T4. So here T4 is not given in the option, so answer is TSH. If you ask me, sir, why not T3? See, T3 per se is not the one that is produced in adequate amounts by the thyroid gland. Majority of the T3 in your body is actually formed by conversion from the T4 to T3. Okay, so usually you will rely on TSH as well as the T4. That is the TSH and the free T4 for establishing the diagnosis of the thyrotoxicosis. So the answer here is TSH. Okay. So it is not free T3, I told you. Ultrasound thyroid can be done as a part of the management, but that's not going to be your initial best test to establish the diagnosis. Anti-TPO can be positive in Graves, can be positive in Hashimoto as well. So it's not going to give you too much idea regarding the what condition the patient is having. But anyway, a female with tremors, sweating, and palpitations and diarrhea, you should be thinking of a condition like that can increase the basal metabolic rate and can predispose to arrhythmias as well. That is thyrotoxicosis. Next question, which of the following is not given in case of a thyroid storm? Is it propranolol, is it lugolcidin, is it aspirin, or is it paracetamol? So thyroid storm management is again important. What are the important drugs that should be given? If you look at the principles of the management of thyroid storm, which I have taught you, you've got to give drugs that decrease the production and release of thyroid hormones like thionamides and inorganic iodine. So that is the lugolcidin can be given. Drugs that inhibit the peripheral conversion of T4 to T3 like PTU, beta blockers, and steroids. Drugs that block the circulating effects of the T4 and T3, that is beta blockers. And also you'll have to deal with the underlying precipitants and provide a general support. So for the treatment, you are having propyl thiouracil, which is given 500 to 1000 milligram orally, followed by 250 milligram fourth hourly. Iodide, that is lugolcidin 10 drops twice daily. PTU is the anti-thyroid of choice, okay, in the management of a thyrotoxic crisis. So it has got a dual action, which I have already taught you. Beta blockers, propranolol 60 milligram orally, Q4th hourly, or you can even go for IV esmolol. Steroids, IV hydrocortisone 300 milligram loading, followed by 100 milligram IV 8 hourly. IV fluids, oxygens, electrolyte and electrolyte imbalance corrections are all important. Now, if you come to this question, propranolol definitely can be given, no doubt it can be given. That's not going to be the answer. Lugolcidin can be given. Is it aspirin or paracetamol? See, paracetamol still can be given because as a part of thyroid storm, the patient can have hyperpyrexia. So there can be fever. And for that, you can give paracetamol as well. So that is not going to be the answer. Aspirin is not actually given in case of thyroid storm. And not just that, if at all the patient was taking aspirin for some reason, in a patient with thyroid storm, you should be very cautious, because aspirin, the problem with aspirin is that they can actually cause interfere with the protein binding and can increase the free levels of the T3 and T4, and that can in fact worsen the thyroid crisis as well. So the answer to this question is aspirin. Okay, aspirin should not be given. Which of the following is not a component of the metabolic syndrome? Is it HDL, fasting plasma glucose, hip circumference, or blood pressure? If you come to the criteria of metabolic syndrome, you will find that these are the parameters that are included. You've got central obesity, but remember, it is not the hip circumference that is taken into account, it is the waist circumference that is taken into account. Now, this is the value that is given in Harrison, but remember, based on the demography, you have got different cutoff values for the waist circumference. Then triglycerides are taken into account, HDL is taken into account, the blood pressure is taken into account, fasting plasma glucose is taken into account. So what is not taken into account here is the hip circumference. It is not hip circumference, it is the waist circumference that is taken into account in case of a metabolic syndrome. Okay. So next question, what is the initial pharmacological management of a 40-year-old female who was diagnosed with ulcerative colitis having 3 episodes of bloody stools per day? So patient is already diagnosed to have ulcerative colitis. Okay, the patient is having 3 episodes of bloody stools per day. How are you going to manage? So remember, in the treatment of ulcerative colitis, I have taught you that it is a chronic lifelong disease with remissions and exacerbations, and the treatment will depend on the extent of colonic involvement and the severity of the disease. So how do you assess the severity? In Harrison, there is one table where they have said, there is a division into S0, 1, 2, and 3. So if there is less than or equal to 4 stools per day, it is the mild category. More than 4, but with only minimal signs of systemic toxicity, is moderate. And more than 6 bloody stools per day with other features of systemic toxicity like a tachycardia, temperature is on the higher side, anemia, ESR is on the higher side, that will be severe. So here it is, it is 3 stools, so you can categorize this patient as having a relatively mild disease. So when you are having a relatively mild disease, say for example mild to moderate colitis, if it is a distal colitis, okay, mild to moderate distal colitis, that is a disease that is confined to the rectum or rectosigmoid, you will give a topical 5-ASA agent like mesalamine as the drug of choice. As a suppository or enema, you can be giving. Okay, so this is the picture which again I have shown you in my routine lectures. So depending on where the colonic involvement is, you will decide whether you give suppositories, forms, enemas, or you can give it orally as well. Whereas if it is not a mild to moderate distal colitis, not a distal colitis, but still a mild to moderate colitis, but extending above the sigmoid colon, it's not exactly very distal. In that case, you will give an oral plus rectal 5-ASA agent. You will give an oral agent as well. So mesalamine oral plus suppository or enema. Only if there is no response, you will go for budesonide or prednisone. Okay. So in this case, they have asked, what is the management? So here, you will be first going for 5-ASA agent. Okay, you will first go for a 5-ASA agent, and only if there is no response, you will think of other agents like a budesonide. Okay. Moving on to the next question. A patient presented with chronic cough, fever, weight loss, and bilateral hilar lymphadenopathy. So any patient presenting with chronic cough, fever, weight loss, lymphadenopathy, in India, the first disease you should be thinking about is tuberculosis, right? So from what I understand from students, tuberculosis was not there in the options. And not just that, there was another important clue, that is the serum levels of angiotensin converting enzyme. Those levels were very high. Serum AC levels were very high. And what is the likely diagnosis? The options are sarcoidosis, and I could not get the other options from the students, but anyway, it is quite clear that the diagnosis is going to be sarcoidosis. This is supported by the elevated levels of serum angiotensin converting enzyme. Okay, right. And sarcoidosis is always a hot favorite for the examiners. You know that this inflammatory disorder is characterized by the presence of non-caseating granulomas. So you can have a multi-system involvement. And always remember, when you talk about sarcoidosis, okay, when you talk about sarcoidosis, you can have commonly a chronic presentation. You can even have acute presentations as well. Okay, so the chronic presentations can involve the lung, it can involve the skin, it can involve the eyes, it can involve the nervous system. So different manifestations can be there. Involvement of the lung can produce chronic cough, most often a dry cough. It's usually a restrictive pattern of lung disease that you get in sarcoidosis. You can have lymphadenopathy, pulmonary infiltrates, and you've got the various X-ray staging systems as well, which I've taught you in my routine lectures. Do you remember? What is the name of that staging system? It is the SCADing staging system. Remember, SCADing staging. Okay. That's the X-ray staging system for sarcoidosis, depending on the extent of pulmonary involvement. Okay. So then you have got the eye involvement. I told you can have granulomatous uveitis can be there. You can have skin involvement either in the form of a lupus pernio or erythema nodosum. You can have nervous system involvement, neurosarcoidosis. You can have bilateral LMN facial palsy as well. Acute sarcoidosis is mainly related to two syndromes. One is the Löfgren syndrome, and the other is the Herford syndrome, which are also important questions. Okay, so the answer here is quite obvious. It is sarcoidosis. What's the drug of choice? Steroids are the drug of choice, right? And just a picture to show you the summary of the various manifestations of sarcoidosis. You can have systemic features, fever, lymphadenopathy. One important electrolyte abnormality that you can have associated is the hypercalcemia, because the non-caseating granulomas of the sarcoidosis, they can cause increased production of vitamin D by activating the 1-alpha hydroxylase. So there can be hypercalcemia. Lymphadenopathy can be there, pulmonary involvement. You can have lymphadenopathy, dyspnea, dry cough, extrapulmonary involvement, anterior uveitis, lupus pernio, facial palsy, sarcoidosis developing at areas of scars. You can have joint involvement, erythema nodosum. So these are various manifestations of sarcoidosis. Next, 40-year-old male is diagnosed as pauci-immune rapidly progressive glomerulonephritis. Which antibody will be positive? So when you talk about vasculitis, you've got large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. And in small vessel vasculitis, there are two groups. Okay, you've got the ANCA positive vasculitis, which is also referred to as the pauci-immune vasculitis. And then you have got the immune complex mediated vasculitis. Immune complex mediated. So the pauci-immune is associated with ANCA positivity, that is anti-neutrophil cytoplasmic antibody, which can either be a P-ANCA or a C-ANCA. P-ANCA or a C-ANCA. Okay. So here they've asked about a pauci-immune rapidly progressive glomerulonephritis. So pauci-immune vasculitis, which can produce a rapidly progressive glomerulonephritis, this can either be a granulomatosis with polyangiitis, that is your Wegener's granulomatosis. It can also be a microscopic polyangiitis. Both these conditions can produce RPGN-like picture. Okay. So which antibody will be positive? The antibody that will be positive will be anti-neutrophil cytoplasmic antibody. Anti-GBM is Goodpasture's, but remember Goodpasture is grouped as an immune complex mediated vasculitis. So it is not a post-immune vasculitis. Okay, right. 40-year-old female presented with bilaterally symmetrical, painful and swollen joints involving the small joints of the hand and wrist. She also complains of early morning stiffness lasting for more than 1 hour, which is the likely diagnosis. So age of the patient is 40 years. Okay, it's a chronic symmetrical arthritis involving the small and large joints along with morning stiffness. So what is the likely diagnosis? It is going to be rheumatoid arthritis. Osteoarthritis, well, it commonly does not involve the wrist joint. It's not a symmetric arthritis with swollen joints, is not a feature of osteoarthritis. Psoriatic arthritis, usually you will have associated skin lesions. Gout, usually it is the first metatarsophalangeal joint that is commonly involved. So because of which the best answer is the most common type of chronic symmetrical polyarthritis, which is rheumatoid arthritis. And again, the early morning stiffness is also a feature that is suggestive of rheumatoid arthritis. Okay, right. All the following side effects are more common with carbamazepine than with oxcarbazepine, except, okay, so allergy, hepatotoxicity, thrombocytopenia, hyponatremia. Okay, see, allergy, hepatotoxicity, thrombocytopenia, hyponatremia, all these side effects can be seen with carbamazepine and oxcarbazepine. But they're asking, all are more common with carbamazepine except. So there is one side effect which is mentioned, which is more common with oxcarbazepine, and that is hyponatremia. So both of them, that is carbamazepine and oxcarbazepine, can produce syndrome of inappropriate ADH secretion. So there can be a hyponatremia, but that is more common with oxcarbazepine. Okay, so allergy, hepatotoxicity, thrombocytopenia, they are all more common with carbamazepine, but hyponatremia is more common with oxcarbazepine. So moving to the next question, a 50-year-old patient was being treated in an intensive care unit for sepsis. Okay, ABG showed pH of 6.9, PO2 of 80 millimeter mercury, PCO2 55 millimeter mercury, and bicarbonate 10 milliequivalents per liter. Repeat ABG after 2 hours showed pH 7.1, PCO2 20, PO2 100, and bicarbonate 10. The question is, what is the likely explanation for the change in ABG report? Is it excess air and less heparin in the ABG sample? Excess air and more heparin in the ABG sample? Less air and more heparin in the ABG sample? Or less air and less heparin in the ABG sample? What do you think is the likely explanation here? See, if you look at the first scenario, you can see that the pH is 6.9. Okay, and in the second ABG, the pH is 7.1. So in both scenarios, you have got acidosis. But definitely there is an improvement of the pH in the second ABG sample. But one point that is interesting is, in the first ABG sample, the bicarbonate is 10 milliequivalents per liter. And in spite of a mild improvement of the pH, you still have got the bicarbonate in the same value. Okay, see, suppose in case of an acidosis and I'm giving the patient some sort of bicarbonate, the pH will slightly improve. But along with that, you should see some improvement in the bicarbonate value as well. But I'm not seeing any sort of improvement in the bicarbonate. The bicarbonate is the same, but still then why the pH showed a slight improvement? That's what I'm thinking about. Okay, you can also see that the PO2, this is 80 here, and in the second case, it is 100, the PO2. Okay, some students also told me that, the recall was 140, whatever it be. Anyway, there was an improvement in the PO2. Some students were saying that the second ABG had a PO2 of 140. And you can see the PCO2 is 55 millimeter mercury. Second ABG, it is 20 millimeter mercury. What is the likely explanation? Now, when you do an ABG, suppose if there is excess of heparin in the sample. Now, what change does that bring about? Remember, heparin has got, being a mucopolysaccharide, it has got weak acidic properties. So if initially the pH, okay, if the pH was say normal, or it is slightly on the alkaline side, if excess of heparin is added, it would make the pH slightly acidic. Okay, it will slightly bring down the pH. But if the initial pH was very less, and then you are adding excess heparin, remember heparin is a weak acid, so then it can actually slightly increase the pH. You got it? It's a weak acid, no? So already you are having a very highly acidotic state. So when you add excess heparin, since it is a weak acid, it slightly increase the pH. Okay. So excess heparin can lead on to, in an acid, if the initial pH was highly acidic, then it can bring about some improvement in the pH. So the improvement of pH without any improvement of the bicarbonate can be attributed due to excess heparin. Okay, can be attributed due to excess heparin. That is possible. Okay. Now, when you add excess heparin, there is also a possibility that you can have some sort of a dilutional effect, because of which the PCO2 can actually come down. So it comes down from 55 to 20. That is because of another property of heparin, that is the dilutional effect. Excess of heparin can produce some sort of a dilutional effect which can bring down the PCO2 concentration as well. But you can see that the O2 has increased from 80 to 100 or 140, whatever. Now this could be because of excess air in the sample. So if there was some air bubbles, that can actually cause increase in PO2, correct? So the likely answer here is excess air and more heparin in the ABG sample. If I am just repeating it, it is the excess heparin that led on to a slight apparent improvement of the pH without a change in bicarbonate, and the dilution effect leading on to a decrease in the PCO2, right? The excess air would have been the reason for the PO2 of 80 just getting converted to 140 or 100. So the answer here is option B, that is excess air and more heparin in the ABG sample. I hope it's clear. Another scenario again of a COPD patient was given, and the pH is 7.3, PCO2 is 80, bicarbonate is 28 milliequivalents per liter, and the options were respiratory acidosis due to hypoventilation with inadequate compensation, hyperventilation with inadequate compensation, respiratory acidosis due to hypoventilation with adequate compensation, respiratory alkalosis due to hyperventilation with adequate compensation. So pH is lower here, PCO2 is actually increased, and bicarbonate is also increased, taking the normal value of pH to be 7.4, 40, and the average value of bicarbonate being 24. So since the change in pH in relation to PCO2 and bicarbonate is in opposite direction, this is likely to be a respiratory acidosis. So there is no doubt about it. The acid-base abnormality, the primary acid-base abnormality is respiratory acidosis, which rules out option B and option D. Okay, option B and option D. Okay, now in COPD patient, you know that this carbon dioxide retention is mostly due to a hypoventilation. So that also is correct. So up to this much is correct. Respiratory acidosis due to hypoventilation, that is why the carbon dioxide is just accumulating. Now, is the compensation adequate or not? Now, if you remember, when I taught you about the ABG analysis, usually adequate compensation means, it will bring the pH to near normal. It will not bring the pH to normal, but near normal, maybe 7.35 or so. That would be an adequate compensation. But again, if you go back to the formulas, if you see in case of a chronic respiratory acidosis, remember I taught you these formulas in case of acute respiratory acidosis and chronic respiratory acidosis. In case of chronic respiratory acidosis, how is the compensation? Remember, for every 10 mm Hg increase in carbon dioxide, bicarbonate will increase by 4 milliequivalents per liter. Whereas in case of an acute respiratory acidosis, for every 10 mm Hg increase in carbon dioxide, bicarbonate will increase by 1 milliequivalent. So the problem here, Since it is a COPD that is mentioned already in the question, you're talking about a chronic respiratory acidosis. So here every 10 mm the bicarbonate should increase by 4. So here you can see there is an increase, there is a 40 millimeter increase. So if there is a 40 millimeter increase, you should have the bicarbonate that is increasing by 4 times, that is 16 milliequivalents. But that is not what you are seeing here. It is from 24 to 28 only. So it is an inadequate compensation is what you should know about. Okay, so in a acid-base disturbance, there is a primary acid-base disturbance and there is a compensation for that primary. In case of respiratory acidosis, it is a metabolic compensation that takes place, but here it is a inadequate compensation that takes place. Okay, you can think it from 2 ways. Even if you forgot the formula, if you look at the pH is not near normal, then it is likely to be inadequate compensation. So the answer here is respiratory acidosis with hypoventilation with inadequate compensation. Okay, right. The next question, based on the volume time plot that is shown, what is the likely condition? So I suppose this was the figure. There was a normal volume time plot that is given. What is a volume time plot? You can see on the y-axis the volume and the x-axis the time. And another graph was given, and this is what you had to comment about. From what I understand, the FEV1 to FVC ratio was decreased. That was also mentioned in the question. See, when you look at a scenario, volume type plot where the FPV1 is decreased and the FVC is also decreased, but a greater decrease is there in the FEV1. In that case, the ratio of FEV1 to FVC will be very much decreased. That is likely to be seen with obstructive lung diseases. So obstructive lung diseases will characteristically have a very much decrease in the FEV1 to FVC ratio. Okay, FEV1 that is seen in case of obstructive lung disease. So that is a feature of an obstructive lung disease. Whereas if it was a restrictive lung disease, okay, let me just show you a restrictive lung disease. In restrictive lung disease, the FEV1 will decrease and FVC is also decreasing. But the ratio FEV1 to FVC, if you take the ratio, will either be normal or maybe slightly increased also. Okay, that is what you see. It's almost a proportionate decrease, or sometimes the ratio, more decrease can be there in the FVC also. So this is what you see in the restrictive lung disease. If you look at the options, out of this, the obstructive lung disease that is there is the bronchiectasis. IPF, sarcoidosis, chest wall abnormalities, all of them usually produces a restrictive type of lung disease. So the volume time plot of a restrictive type of lung disease was given. Obstructive type of lung disease was given, and the answer is bronchiectasis. What are the other obstructive lung diseases you know about? Bronchial asthma, COPD, they are examples of obstructive lung disease. Remember, in your exams, there is also a chance that instead of the volume time plot, they can give you the flow volume loop as well. So based on the flow volume loop also, you can differentiate between obstructive and restrictive lung diseases. I have taught you in my lectures. That is also very, very important for your exams. Okay, it can be asked in the upcoming exams as well. Okay, right. So just have a quick look at the various obstructive lung diseases. COPD, asthma, bronchiectasis, cystic fibrosis, alpha-1 antitrypsin deficiency. These are the obstructive lung diseases. Restrictive lung diseases, interstitial lung disease, hypersensitivity pneumonitis, myasthenia gravis, kyphosis, ankylosing spondylitis, and morbid obesity. These are the restrictive lung diseases. Okay. A patient who develops stroke complains of inability to identify objects, but can identify the color, texture, and shape of objects. Which of the following lobes is involved? So the patient has inability to identify certain objects following a stroke. But remember, he can identify the color of the object, the texture of the object, and shape of the object. Now, this is actually a scenario of a visual agnosia. Okay, visual agnosia. So the patient can see, he can see the object, but he's not able to identify the object. It's called a visual agnosia. And in my lectures, I have told you that there are two types of visual agnosias. One is an apperceptive visual agnosia and other is associative visual agnosia. Apperceptive and associative visual agnosia. Now, in case of apperceptive visual agnosia, the patient will not be able to appreciate the texture. Both are visual agnosias, but the problem is, suppose if I am showing the patient a cubical structure, okay, apperceptive visual agnosia, the patient will not be able to form a percept of the image as well. He is not able to identify this as a cube. So the percept will not be there, apperceptive visual agnosia. In that case, he will not be able to identify what is the shape of the object as well. You show him a cube, he will not be able to find. But associative visual agnosia means, this is important, it means the patient can identify the shape, the patient can identify the color, everything about the object. But if you remember my lecture, the patient cannot recollect this from his semantics. Matlab, he's seen the object, but he exactly cannot remember what it is. What is that object? Because see, if you see a glass, and if I have got to say that this is a glass, from my memory, I know that this is a glass. Seeing the shape of this, I should remember, oh, this looks like a glass. Okay, I should remember like that. But here, I have seen this object glass, but I am not able to take it out from my memory. That is an associative visual agnosia. So actually, what is the diagnosis here? It is visual agnosia, but not any visual agnosia. It is associative visual agnosia. And in associative visual agnosia, if you look Harrison as well, this happens due to inferior temporal lobe lesions. This happens due to inferior temporal lobe lesions. So the answer to this question here is temporal lobe. Okay, right. So next question, comment on the diagnosis based on the following serological profile: HBsAg negative, anti-HBs negative, HBeAg negative, anti-HBe negative, IgM anti-HBc negative, total anti-HBc is positive. So what it is? So remember, HBsAg is negative. HBsAg is negative. Okay. And anti-HBs is negative. So look at the options. Hepatitis B in the chronic remote past, chronic hepatitis B carrier, post hepatitis B vaccination, and window period. So see, in case if it is post vaccine status, the only thing that should be positive is what? Anti-HBs. Okay, the anti-HBs titer should be positive. But you're not seeing that, so definitely this is not going to be option C. It's not a post-vaccination scenario, because in that case you will see anti-HBs positive, and it's the only thing that is going to be positive. You will not see a total anti-HBc. See, IgM anti-HBc is negative, total is positive, matlab it is, you're talking about IgG. IgG anti-HBc is positive. Now coming to window period. Okay, window period is not the answer. Why? In window period, it is IgM anti-HBc will be positive. So in window period, the IgM anti-HBc should be positive. So that is also not the answer. Is it hepatitis B infection in the remote past, or is it a chronic hepatitis B inactive carrier? That is a question here. Now if you look at this, see, if it was a chronic hepatitis B inactive carrier, even if it is inactive carrier, if it was chronic hepatitis B, what should have been positive? HBsAg should have been positive. That is also not the answer, because in that case, HBsAg should have been positive. So what is the answer here? It is a hepatitis B infection in the remote past, which is why you have got an anti-HBc positive. So you remember, I've always stressed this. This table from Harrison is very, very important for your exams. Okay, on the various serological patterns of hepatitis B infection. So this is something which is always to look out for, frequently asked in INICET as well as your NEET PG exams. Okay, so let's go to the next question. So match the following: cystic fibrosis, Duchenne muscular dystrophy, Leber's hereditary optic neuropathy, and myotonic dystrophy. It's a simple one. So cystic fibrosis is autosomal recessive. Duchenne muscular dystrophy is X-linked recessive. Leber's hereditary optic neuropathy is mitochondrial, and myotonic dystrophy is autosomal dominant. So the answer is option A. Patient presented with fever, headache, and neck stiffness. Kernig sign was positive. So you're thinking about a meningitis case here. there is opening pressure elevation, so obviously meningitis, but it is a lymphocyte predominant meningitis with elevated protein and decreased sugar. You can see for an RBS of 140, the glucose is 20 only, so very much, normally it should be at least 2/3 of RBS. Normal CSF glucose should be 2/3 of RBS, but it is very less than that, so there is a hypoglycorrhea. So what is the diagnosis here? So bacterial meningitis will be neutrophil predominant, that's not the answer. So it's between tubercular and viral. Viral meningitis, protein can be elevated, lymphocyte predominant, yes, but glucose will be normal. Since the glucose is reduced, it is not going to be viral meningitis. Since the glucose is reduced, it is likely to be tubercular meningitis. So that is the answer here. Patient with recent COVID-19 and was given steroids. He presents with nasal discharge for the past 3 weeks. Histopathological image was given. What is a likely diagnosis? So COVID-19 infection, the patient being given steroids, now presenting with nasal discharge for 3 weeks. And if you look at the histopathology, you can see that, aseptate hyphae with right angle branching, you are thinking about mucor. Okay, so the answer is mucormycosis, which is again a very common infection that develops in patients with COVID-19. So mucor is aseptate with right angle branching of the hyphae. Okay, right. Next, patient on ampicillin therapy for upper respiratory tract infection develops pseudomembranous colitis. What is the treatment is what is being asked. So treatment of pseudomembranous colitis, remember the Clostridioides difficile, which colonizes the human intestinal tract, typically after the normal gut flora has been altered by an antibiotic therapy, will cause the pseudomembranous colitis or the antibiotic associated colitis. And what are the common antibiotics that are implicated? One is definitely the penicillins. So the question also gives you about ampicillin, which is a penicillin. And also fluoroquinolones, clindamycins, and cephalosporins can also produce the condition. So regarding the treatment, this is the treatment of the pseudomembranous colitis from Harrison. You can see fidaxomicin is preferred. You can also use vancomycin. The option has only fidaxomicin. So fidaxomicin is the answer here. That is a preferred treatment. Okay. Fluoroquinolones actually can cause pseudomembranous colitis. Patient on treatment for MDR-TB presents with weight gain, cold intolerance, and lethargy. Lab evaluation showed elevated TSH, low T3 and T4. Which drug is responsible? So in a patient on treatment for ATT, now complaining of weight gain, cold intolerance, and lethargy, with lab evaluation suggestive of hypothyroidism, what drug is responsible? Okay. So it is a hypothyroidism. So when you think about hypothyroidism, one drug that can produce is ethionamide. What is the other drug that can produce? PAS also can produce. So ethionamide can produce drug-induced hypothyroidism. So that is the answer. Elevated TSH, low T3, T4. That is suggestive of hypothyroidism. Okay, look at this picture from Harrison. This is ethionamide. Ethionamide can produce hypothyroidism as one of its side effects. Okay. Patient on ATT develops multiple joint pains. The serum uric acid was elevated. The liver enzymes were normal. What should be done? So patient is on ATT again and his uric acid is elevated. Okay, he's having arthralgia as well. Liver enzymes are normal. What should be done? So you know that pyrazinamide can produce hyperuricemia. So how to deal with a pyrazinamide-induced hyperuricemia? Should you stop pyrazinamide? No. See, the problem here is pyrazinamide can produce elevation of uric acid. Now, suppose if pyrazinamide produces a hyperuricemia and then that results in gout. Here, they have not said that the patient has got gout. Okay, there are some arthralgia, but it has not gone into the gouty stage. If it was the case, you could have started the patient on allopurinol as well, and then thought of modifying the dose of pyrazinamide as well. But here the patient is having arthralgia. Okay, since there is arthralgia alone, in that case, what is suggested is you can add salicylates like aspirin. So what salicylates will be doing is that salicylates in high doses, like high dose aspirin is uricosuric and will lower the uric acid. So what you should be doing here is, in this scenario, you should be adding a uricosuric, but that uricosuric medication is what? Salicylate. Salicylates in high doses. Remember, low dose aspirin blocks urate secretion and raises serum uric acid. So low dose matlab the dose is less than 2 gram. So if you give higher doses, it will act as a uric acid, uricosuric medication. This is what is actually mentioned in our national guidelines. So the national guidelines for India also says that if you have got arthralgia without a gouty arthritis developing, all you do is you add some salicylates and continue pyrazinamide. Okay, but if suppose a patient had the gout developing, then you can think of adding allopurinol, only if the gout is there. Just for an arthralgia, there is no definite benefit of adding the allopurinol. And see, they have clearly said that, even if you want to, plan to change pyrazinamide, that should be taking into consideration everything. It should not affect the treatment, because what is most dangerous? It is tuberculosis that is most dangerous. So only in, a very dire scenario, you will think of changing pyrazinamide to another drug. Okay, right. Patient with dengue fever with a platelet count of 98,000 and no bleeding manifestations came 2 days after the onset of symptoms. All the following can be used to diagnose dengue except. So this is a question regarding the diagnosis of dengue fever. You can see that the platelet count is 98,000 here, and he is coming 2 days. Some students said that the recall was 3 days. So, I got some students actually were saying that it is 2 days, 3 days, but whatever it is not going to produce a change in the answer. So if in the first week, you can go for NS1 antigen, you can go for viral culture, you can go for PCR. For the IgM dengue, you have to wait. Only in the second week, you will be having a positive antibody. Only beyond 5 days, it will start, mostly in the second week. So all the following can be used to diagnose except IgM dengue antibody. Severe dengue is characterized by persistent vomiting, hepatomegaly, ALT increase more than 1000, decreased WBC and platelet count. So if you remember my lecture on dengue, I have told you about 2 classification systems for dengue. One is the old classification system, but which is still being used. That is the 1997 WHO classification into dengue fever, dengue hemorrhagic fever, and dengue shock syndrome, and the 2009 WHO classification into dengue without warning signs, dengue with warning signs, and severe dengue. So here they are asking about severe dengue, not about warning signs. So warning signs means the abdominal pain, tenderness, persistent vomiting, signs of fluid accumulation, mucosal bleed, hepatomegaly more than 2 cm, rapid increase in hematocrit with a fall in platelet count. All these are warning signs. But when it goes to a severe dengue, what are the features suggestive of a severe dengue? You look at this, dengue classification by severity. So they have listed again the warning signs. Severe dengue, you look at this. You will have features of severe plasma leakage, severe bleeding, but severe organ involvement, ALT more than 1000. Okay, significant elevation of ALT will be there. So this ALT increase more than 1000 is a feature of severe dengue. The other features like persistent vomiting, hepatomegaly more than 1 centimeter, they are all features of they're all warning signs. They're all warning signs. Okay. Next is a patient presented with fever, headache, myalgia, and cough. On examination, there was a black scar over the patient's chest. Auscultation showed bilateral crepitations. Blood investigation showed positive IgM for scrub typhus. What is the treatment? Is it IV doxycycline plus azithromycin, oral doxycycline, and oral azithromycin? Okay. See, if you look at this, clinical scenario is that of a scrub typhus. You can see black scar. Definitely it is scrub typhus. No doubt about it. Okay. But you can see there is one complication. There is a pulmonary involvement as well. Okay, pulmonary involvement as well. And they have asked about the treatment as well. Now, this might be slightly controversial for students because see, the current guidelines, what is given in most references, in case of a severe scrub typhus, you will have to go for parenteral medications, no doubt. So you can cut these 2 options. But even now, most of the guidelines, they say it is IV doxycycline as a single agent. Can't you not combine doxy and azithromycin? Well, azithromycin is also useful for dengue, but most of the current guidelines, they do not see any added advantage of combining both. You either give doxy or azithromycin, but there is no point combining both is what most guidelines say. So I feel the answer for this should be IV doxycycline. And why I say I feel is because there are some research papers which actually say you can try IV, doxy plus azithromycin as well. But again, at your level, appearing for an exam, I feel the safest answer in most of the reference textbooks will be IV doxycycline for scrub typhus. Then there was a question on clinical scenario of a pneumonia. I did not get the exact recall of the question from the students, but from what I understand, it was a clinical scenario, and you were asked to find out the CURB 65 score, and the question was about the management of the patient based on whether it is IP patient or OP patient, like that. That's what I assume from the students. But just for your knowledge, you understand that CURB 65 is CURB, confusion, urea more than 7 millimole per liter, respiratory rate more than or equal to 30, blood pressure systolic less than 90, diastolic less than 40, age more than or equal to 65 years. Okay, so if I think the question also, urea more than, there is a blood urea more than 40. Okay, that will be the conversion. So the blood urea is more than 40, which is corresponding to the more than 7 millimole per liter. So if the CURB 65 score is 0 to 1, the patient can be managed OP. If it is 2, it is IP in the ward, whereas 3 or more, it is IP in the ICU. So first of all, you have to see the question and look where the patient has to be managed. Is it in the IP ward, or is it OP, or in the IP ICU? Now, in case of an outpatient community-acquired pneumonia, what is going to be the antibiotic choice? Because the question that was asked was which antibiotic has to be given to the patient. So some students told me that based on CURB 65, it was outpatient community-acquired pneumonia. Some students told me, sir, it was inpatient in the ward. So I'm just giving you both these scenarios. So outpatient community-acquired pneumonia, if the patient had an antibiotic treatment within the last 3 months, or if there are comorbidities, in that case, you will go for amoxicillin plus clavulanate, TID, or levofloxacin 750 milligram OD. This is given for a period of a minimum period of 5 days. If it is no, then azithromycin 500 milligram on day 1, followed by 250 milligram OD, that is given for the remaining 4 days, or doxycycline 100 milligram BD, that is again given for then around a week or so. That is outpatient community-acquired pneumonia. Inpatient community-acquired pneumonia, again minimum 1 week treatment. But this is what most students told me, sir. There was an option with beta-lactam plus fluoroquinolone. So here you give injection ceftriaxone 1 gram BD plus injection levofloxacin 750 milligram IV OD. And if at all it is a severe pneumonia, then you have to give MRSA or Pseudomonas coverage. But for this question, from what most students told me, it was an IP community-acquired pneumonia in the ward, and there was an option with a beta-lactam plus a fluoroquinolone, which is the answer. Okay, which of the following structures is essential for permeating the viral RNA through the host cell membrane? Is it GP41, is it CCR5, CXCR4? Okay, CXCR4, or is it GP120? Okay. Now this also was slightly confusing for the students, because actually all these are important in the entry of the viral RNA, but I would slightly stress on this word, permeating. Why means, you just have a look at the structure. You can see this is the GP120, then there is a transmembrane protein that is GP41. If you remember the HIV life cycle that I've taught you in my lectures, the first step is the attachment of the GP120 to the CD4 receptor. And when you get an attachment of the GP120 to the CD4 receptor, just have a look at this picture which I'm going to show you. This is GP120 interacting with the CD4 receptor. As a result of that interaction, what will happen is that this will lead to a further cross interaction between the GP120 and the co-receptor, that is CCR5 or the CXCR4, because of which you will have this GP41, which actually changes its conformation, attaches to the viral side as well as the host side, and that actually brings about the membrane fusion, resulting in the permeation of the viral RNA into the host cell. Okay, that is actually final, that is the important step that is responsible for the transfer of the viral RNA contents to the host cell. So in that case, I think the best answer here should be, about the GP41 here. So I think the best answer was GP41. Okay, so here I am going for GP41 here. Okay, because most students told me this word was there, permeating was there. If it was asked about the first step of attachment, no doubt, GP120. If you're asking, see, sir, all the options are important, but if specifically they're asking about permeating, this answer should be GP41. Okay, right. So, HIV positive patient presented with neck stiffness and papilledema. CSF showed a capsulated organism positive for India ink staining, which of the following statements is true. So, HIV patient, positive patient with neck stiffness, most likely it is a meningitis with raised ICT, there is papilledema. Capsulated organism positive for India ink staining, we are probably talking about a cryptococcal meningitis. Cryptococcal meningitis. We're talking about a cryptococcal meningitis. Initiate treatment with amphotericin B alone is wrong because you have to combine the flucytosine as well. It's not alone. You have to combine amphotericin B plus flucytosine. Normal CSF pressure again is wrong because they themselves have mentioned that there is papilledema, so CSF pressure should be elevated. 80% cases can show abnormalities in MRI brain. See, it is a meningitis, so if you do a plain MRI brain, many cases may have a normal MRI. Some cases may have the appearance like, that soap bubble appearance may be there, but in a plain MRI brain, you will not have 80% cases having the abnormalities. If you go for a contrast MRI, you might have the meningeal enhancement, but it was just mentioned 80% will show changes in MRI brain is wrong. Okay, and delay antiretroviral therapy for 2 to 3 weeks. It's right. You can even delay up to 4 weeks as well. This is actually to prevent immune reconstitution inflammatory syndrome, that is IRIS. So this is the answer here. Delay the antiretroviral therapy for 2 to 3 weeks to prevent IRIS. Okay, right. So coming to the next question. HIV patient on ART presents with the features of bleeding diathesis and also headache, vomiting and altered sensorium. Which drug is responsible? So this is based on the side effect of a drug which is a protease inhibitor. So if you look at this, I've taught you in my lectures on the various drugs available in the regimen, and in the protease inhibitors, in the national guidelines, you have got ritonavir, lopinavir, atazanavir and darunavir. But the question they have asked is not about any of these drugs. They want to just test you about a drug which is not a part of our national program. It is tipirnavir. So the tipirnavir is likely to cause complications like bleeding tendencies. It can cause headache, vomiting and altered sensorium because it can even cause IC bleed. Okay. So HIV patient on ART with features of bleeding diathesis, it is likely to be due to tipirnavir, which is a protease inhibitor. Okay. Then coming to the last question of the discussion. There was a clinical scenario of a poisoning, and one point that students mentioned was it was specifically mentioned about pinpoint pupils, and one of the options was opioid poisoning. It is right. Opioid poisoning can produce pinpoint pupils. I also want you to know about other causes of pinpoint pupils. Remember, organophosphate poisoning can also produce pinpoint pupils. Horner syndrome, pontine hemorrhage, iridocyclitis, the drug clonidine, as well as various antipsychotics, they can also produce pinpoint pupils. Okay, so that also you have got to keep in mind because next time they can slightly twist the question. So that's it about the discussion of the various questions asked for the INICET November 2023 paper.